Welcome to VA GLA Hospitals Division Faculty Development Series. This lesson is on preparing learners for management of nutrition in the hospital. On ACGMA Clinical Educator Competency, it falls into ETP1, Teaching and Facilitating Learning, or ETP7, Learning Professional Development. I hope to help your learner to understand value of malnutrition, to diagnose it, document it, and use all available resources in the hospital to address it. ASPEN defines malnutrition in hospitalized patient as very serious health issue associated with higher cost, longer stays, and increased mortality. Malnutrition is associated with huge economic burden, higher human cost, and longer hospital stays. The rates of malnutrition is the highest in our older patients. Global Leadership Initiative on Malnutrition established 4 easy steps to move along addressing, diagnosing, providing support for malnourished patients, and transitioning their care to outpatient. Let's go over the steps. Before we start, I would like to bring your attention to the modern definition of malnutrition. It's now defined as acute, subacute, or chronic state of nutrition in which combination of overnutrition, like in obesity, and undernutrition with or without inflammation leads to change in body composition and diminished function. So starting with step 1, we need to screen for nutrition risk. There are numerous tools available for it. Majority of US institutions, including our facility, uses nutrition risk assessment or nutrition risk screening 2002. You don't need to worry about it, as any tool can be used and is used in first 24 to 48 hours of patient's hospital stay. And any registered dietitian or nutrition services technician will do the screening for us and document it in the note. So nutrition risk screening 2002 assesses 5 parameters: weight loss, recent food intake, BMI, severity of disease, and age. And if the score is 3 or more points, this patient is defined as at nutrition risk. Once patient is determined to be at risk, we move to step 2 and work on diagnosing malnutrition. ASPEN provides the whole long algorithm on how we move on along these lines: screen, evaluate, and treat patient. We don't need to know all that, but our dietitians religiously follow these guidelines. So to diagnose malnutrition, patients need to meet at least 2 of the following criteria: insufficient food intake, weight loss, loss of muscle mass, subcutaneous fat, localized or generalized edema, and diminished function measured by hand grip strength. At least 2 of those, and you made your diagnosis. Alternatively, Global Leadership Initiative on Malnutrition, or GLIM, created 2 types of criteria. Meeting 1 of each, phenotypic criteria and etiologic criteria, will make the diagnosis of malnutrition. It's very important, once the diagnosis is made, to document it. Of course, we expect that registered dietitians will do it in their notes and add malnutrition to the problem list, but medical doctors need to do the same. Please remind your interns and other trainees that malnutrition needs to be part of patient chart. It needs to be mentioned in daily notes. It needs to be supported by the exam findings, and it needs to be addressed in our treatment plan. Finally, please don't forget to add it to the discharge summary. Moving on to step 3. How do we provide personalized nutrition support? Before you do it, we need to know what caused malnutrition. And there are many reasons why our patients in the hospital are not eating. It can be because they have inadequate dietary intake due to dysphagia, medical condition. They may not be eating because of depression. They may not have enough food or have nausea caused by medication. Other reasons for malnutrition could be anorexia, sarcopenia, or cachexia, and treatment for all of those could be individualized. The first step can be as easy as lifting dietary restrictions. In many cases, the dietary restrictions are not necessary, like discontinuing your MPO order or removing low salt or low fat diets and replacing it with the regular diets. Some patients, especially those with low dexterity, will need the tray set up or feeding assistance. Next step is adding snacks or preferred food to patients' tray to make sure that they eat when they want and what they want. In general, multivitamins are not recommended for all malnourished patients, but if you suspect vitamin deficiency, it's easy to correct by providing daily multivitamin. Oral nutrition supplements is a next step in providing adequate calories to the patients. Appetite stimulants can be used for patients with anorexia. There is in general a low level of evidence on its use, except for mirtazapine, which has been supported by at least 2 inpatient trials where patients successfully gained weight. Other appetite enhancers, such as megestrol acetate, can be associated with unnecessary side effects. Megase can cause edema and congestive heart failure. Dronabinol use also falling out of favor because of unacceptably high rate of CNS side effects. This is additional information on oral nutrition supplements for your interest. Enteral nutrition can be indicated in patients who are unable to meet their needs orally, even with ONSs. Within 24 to 48 hours in critically ill patients, and after 1 week in non-critically ill patients, as long as the GI tract is working properly. Enteral nutrition is contraindicated in patients who can eat and those who are unable to use GI tract for their nutritional needs. It's also contraindicated in advanced dementia and not recommended at the end of life. We always prefer enteral nutrition to parenteral nutrition because it supports healthy gastrointestinally associated lymphoid tissue and protects tight junction proteins. It also activates normal incretin pathways and provides normal biliary flow. On the opposite side, parenteral nutrition increases the risk of multiple complications and in general is more expensive. However, in selected situations, parenteral nutrition can be indicated. It is so in non-functional or non-accessible GI tract. Such situations include ileus, small bowel obstruction, and ischemic bowel. It is also indicated in malabsorptive conditions, such as short bowel syndrome and severe IBD. Finally, failed nutrition trial, despite appropriate gastric tube placement, can require parenteral nutrition support. In order to meet criteria for parenteral nutrition, patients will need to require it for at least 7 days. In order to receive parenteral nutrition in our institution, trainees need to request nutritional support team consult. Finally, step 4 is transitioning patients to their home environment and screen them for food insecurity. Of course, your trainee will need to develop a plan of care with your assistance. The registered dietitian will place outpatient nutrition referral and will order 1 month supply of either oral nutrition supplement or tube feeding as necessary. Any patient education regarding their dietary recommendation will need to be provided. And very importantly, please try to connect your patient with limited resources with beneficial organizations like Meals on Wheels and Project Angel Food. These two nonprofits can provide home-cooked meals, even medically adjusted diet, such as low salt or cardiac diets. In summary, malnutrition in the hospital is associated with higher cost, longer stay, and increased mortality. Recognizing, documenting, and addressing it is a very important part of patient care.